Stop the recordings. No. All right. So I think we'll start. And yeah, so this question about tell me about an interesting case. They can ask it, of course, in numerous ways. They can ask, okay, tell me about a case that you managed. Something that's out of the ordinary. All right. Do you have um, any case that was a bit unique or peculiar? So they can use different terminologies, but what they really want to do is make sure that you know how to present a case, especially people from IMGs who normally have done or are doing some type of clinical work, house job or anything similar that would allow them to know how to present a case. Um, Usually that's what they're looking for because that is very important. That's what you do in a residency. Every single day you are presenting cases to your attendings in the morning, especially, well, anywhere. If you're doing family medicine, you are presenting cases because you get to see the patient first, and you have to put together the patient's history, presenting complaints, everything, lab work, imaging, everything. You have to consolidate your answer, and you have to present the case to your attending. So that's what you basically do in residency. And they expect that if you have mentioned in your CV that you have this and this experience, that you're able to present a case, right? Yeah. All right. So let's give a small example just to get the ball rolling. Um, let's say, for example, yes, I did have a fascinating case. At least for myself, it was pretty fascinating. We had a 58-year-old African American female presenting with fatigue and no significant past medical history. She states that her fatigue has been gradual in onset over the past couple of months, where she has noted that she has been unable to climb stairs without feeling short of breath. And if she has to do any exertional activity, that also results in shortness of breath. This was associated with a dry cough over the past couple of months. Denies any significant phlegm production, denies any fever, chills, otherwise. Denies any associated palpitations or chest pain. She otherwise on vitals, not significant. Um, Oxygen saturation was on the lower end, 92% on room air with exertional activity. Otherwise, physical exam findings not significant with no crackles, rales, or wheezing noted on the physical examination. Subsequently, lab work revealed hyperkalemia with a calcium level of 12.5 milligram per deciliter. PTH levels were also obtained subsequently, which were noted to be suppressed. Imaging was obtained. Chest X-ray revealed bilateral hilar lymphadenopathy. So this led us to pursue further investigations, and the thought in our mind was possible sarcoidosis. The patient was initiated on steroid therapy, and also the patient received a subsequent biopsy. After the steroid therapy, the patient's condition did improve. Subsequently, the biopsy came back positive for sarcoidosis. This case definitely was interesting for myself. One, because this was my first case of sarcoidosis. Of course, we heard about sarcoidosis in textbooks. However, I was able to gather the history from the beginning and monitor and managed and monitored the patient for the next couple of days while I was on service. Subsequently, I was also able to follow up on the pathology report, which confirmed the diagnosis of sarcoidosis. Yes, this was truly interesting for myself, and hopefully you have liked listening about this case. Okay. So basically, you present a case. That's, I believe, the best way to answer these questions. All right. So, who wants to go? Who has the interview coming up on the 22nd? Well, then the show is yours. I can't hear you. I think you're on mute.
Okay, so should I start?
Yeah, so Dr. Hassan, so it seems you have some significant amount of experience. You did your house job, right? Or you're in the middle of your house job?
Yeah, I have done my house show.
Oh, great. What was it in?
It was basically I've done house show for like 6 months, 3 months in the internal medicine and 3 months in the surgery. Then I came for the clinical experience over here in the United States.
Okay, wonderful, wonderful. So anything, any case that you remember that was interesting, that you could talk about?
Okay, so from my house job or from United States clinical experience?
Well, any case that you remember and you feel
Yeah,
that really resonated with your practice of medicine.
yeah, sure. Okay, so I was recently doing a clinical rotation at University of Wisconsin, where there was a young female 21-year-old female patient who had type 1 diabetes mellitus and who underwent multiple organ transplants, kidney, pancreas, and the liver, and she was on the long for the long time she was on the immunosuppressive therapies, due to which she developed a multi-drug resistant bacteremia and the fungemia, and then over the time she progressed to uh, end-stage renal disease and then on hemodialysis and ventilator dependent. So she was on GJ Fusion tube as well. So over the time, the what made this case much more challenging was not just the medical complexity of the case, because the patient was there in the hospital for more than a year, and the parents of that patient wanted every possible intervention despite the poor prognosis of the case. So what happened over there? It taught me the importance of compassionate communication and respecting the values of the family in the end decision of the in end of the life care decision making, and the collaborative interdisciplinary approach of the different specialties for that particular patient, and how to handle the pressurized situations like this. So this case was really impacted me a lot and told me so many things, because being in the hospital for such a longer period of time, and the ethical and dimensional and other emotional dimensions of the patients and their parents involved with this case were really, this made this case really interesting for me.
All right. All right. Any feedback from other folks? Any thoughts about his answer? Any?
But I think it was an interesting case.
Okay. And all right. Anybody else?
Um, I had a case where it wasn't really unique in any capacity, I would say. But do you think I should still mention it because I was very involved with the patient, with their management?
Uh, it it all depends on how you present it and
Mhm.
why do you think it was worth for you to describe the case? If you say
Okay.
that you really and I mean there has to be some significant aspects of the management
Mhm.
um, uh, that was noteworthy that you felt that you out of the many cases that you have seen
Mhm.
that stands out.
So can I describe it really quickly?
Sure.
Dr.
So,
Khan, I want advice regarding one thing
Oh,
regarding.
that's yeah. So I think so. What did the patient, was it an inpatient setting? What did the patient present with? We know that
So
she has
basically,
diabetes. Let me just so I think your the interesting part was that the family wanted everything done, and she had multiple issues.
yep.
Um, so so let's say, for example, you are presenting a patient in morning rounds.
Mm-hmm.
That's the approach that I prefer, that I feel that is probably the best approach to take. For example, even in Pakistan, if you had a house job, you're seeing your patient and you're presenting it to your attending who's coming to the ward, right? So
Yep.
that's how you should look to present the patient. Patient is on the ward. You went there in the morning, 6 o'clock, getting ready for rounds at 7 o'clock, right? Something similar, or 8 o'clock, whatever. So that's should be the approach you should take to present a patient. Um, so they're judging, so that's like I was mentioning, that is what you will do every single day in the morning of your residency. So they want you to present a case in a presentation style, and you don't have to go into every single detail, just the positives, the real positives, the pertinent, important aspects of the case. And then you mention, okay, why this was interesting. Okay, what was my role in this case? What was I doing? So, I mean, that's an interesting fact. That's something interesting. Okay, the family wanted everything done. I mean, the woman is 21 years old. It's not surprising. Family with patients who have been, 70, 80 years old, who are ventilator dependent, they still want everything done. For 21-year-old, obviously they will want everything done. So my point was that I think when you were describing the history, it didn't make any sense. Why did she need all these transplants? Why did she become respiratory? Why she has respiratory failure? How did she develop? Um, how did she get on to dialysis at the age of 21? So a lot of I think you just need to organize that answer. Um, and if it's just a case that was interesting to you, that you saw when you were an observer, that's fine. But I think you still need to present it. So possibly it's better if you present something from Pakistan where you had a case that you really did some work on.
Yeah.
This
Okay.
patient you probably didn't do anything for. You're an
Sure.
observer. You don't do
Sure.
anything. They want to see if you are a resident that will work for them.
Mm.
And if somebody says, okay, yeah, I have had house job, 3 months in medicine and 3 months in surgery, or whichever, that's pretty reasonable. And so if we are writing that we have it, then they will expect that you're able to have at least a couple of patients that you remember, that you can talk about. Um, so I think you should probably go for at least prepare two cases at least that are in a presentation style, that
Okay.
you're attending in the morning, just like
Okay.
you probably did in your house job.
Okay, Dr. Hani, but if we will go in too much detail, like in the presenting style, it will take much longer time. Like
How
mostly they say to complete it in just 2 minutes,
how long did I take?
maybe 3 minutes.
Okay, you failed me then. But you need to understand what I'm saying. What do you
Yeah,
think?
I got your point.
Okay, so take that in and prepare two questions that are like that,
Okay.
because I think you start off with lady coming in, 21 years old, um, and you have to go step by step. Chief complaint of this, past medical history this, um, further review systems this, pertinent vitals, pertinent
Yeah.
physical exam findings, pertinent positive laboratory investigations. What did imaging disclose? What was the initial thought? What was the initial impression? What did
Mhm.
you do for the patient? They don't want to hear, I mean, they're not here for a story. They're here to know if you are a good resident or if you will be a resident that will, you know, they don't have to teach too much. So that there's one benefit if you have, if somebody they're getting from Pakistan or somewhere else over the Caribbean grads that you are usually going to be competing with, they generally may not have the experience of a house job that you probably have. So they'll say, okay, I mean, the Caribbean guy is probably speaks better English, but you may have experience. You may know how to intubate. You may know how to put on a central line, or you may know how to present a case. So that's what they're looking for. Um, so just yeah, put things down to paper. You should have at least two, three cases written down properly.
Okay. Thank you so much for your suggestions.
All right, who's next?
Can I go next?
Sure.
Sure. Thank you. So the case that comes to mind for me is the very last one I saw during my house job. It was a case of preeclampsia. The patient presented to us with headache, and on examination, we found her blood pressure was elevated, so we ordered the relevant investigations. And on that, we discovered she had proteinuria on her urine test. Um, Shortly afterwards, the patient went, look, before that, we administered magnesium sulfate and labetalol to manage her blood pressure, and the magnesium sulfate to prevent her from going into eclampsia and developing seizures. Shortly afterwards, she delivered her baby, but after that, her blood pressure remained highly elevated. Uh, and we gave her 3 or 4 more doses of labetalol, but her blood pressure would not come down. And in fact, at one point, it went above 200, the systolic blood pressure. Um, so we ended up consulting the anesthesia department, and my previous rotation happened to be anesthesia as well. Uh, and they suggested some medication to us. It was mostly nitrates that we used. And I had some experience administering those medications. So the gynecology department, or actually the residents I was working with in the gynecology department, suggested that I mostly oversee this case because they weren't experienced with using nitrates to manage hypertension. And I was the one that was mostly overseeing this patient. And I was deeply involved in the management of her case while she was with us in the labor room. So for like a good 4 to 5 hours, I was the one that was routinely administering her medication, titrating the dose. Um, Unfortunately, her blood pressure did not lower too much while I was there, but I did check up on the patient about an hour after I left when my shift had ended. Uh, Unfortunately, her blood pressure came down. So that was something uh, I look back on very fondly because I played a major role in managing that patient's blood pressure. And I got to use the knowledge and experience I gained in the anesthesia department to manage this patient.
All right, that's interesting. And of course, yeah, your last, maybe your first patient and your last patient are more memorable. Um, yeah, you said you were titrating some medication. Was the patient on a drip, perhaps? What drip did you start?
I have it written down, so I'll have to like look that up exactly.
Okay, so
Mhm.
uh, make sure when you are, you're ready for that. Just
Okay.
they can ask you anything about the case. That's the thing. So whenever you present a case, make
Mhm.
sure it's the same thing as in your CV. Everything was open game from your CV. So
Mhm.
when you're presenting a case, just know the basics of what you did.
Okay. So in my case, this was like 3 years ago now. So I don't remember the exact details. It's mostly vague,
Right.
but I have the medication written down because I had to forward it to the resident as well after I left. So I do remember the like I have it written down somewhere.
Right. So yeah. If you have gaps in the case,
Mhm.
plug in the gaps.
Okay.
Because they will say, okay, you probably knew that this was a question that's going to happen and somebody's going to ask. So you should
Hmm.
have a case that that you do know about, right? So
Hmm.
yeah, even if I mean it's probably is not so easy to get medical records from Pakistan. It's probably not that easy.
Hmm.
But I would suggest that, and if you do plug in the gaps, make sure those are, that's reasonable,
Hmm.
from a medical standpoint.
Okay. Thank you.
And I would just structure it just a little bit more. I think, it was okay. Probably structure it again a little bit more. Um,
Hmm.
I don't know, I've forgotten how old was the female?
About 30 years old.
A 30 years old female. Um, so with eclampsia, all of these things, you have to say, okay, gravida one, how many pregnancies, you have to
Hmm.
explain that, because it becomes very important. Has the patient had this before in a previous pregnancy,
Hmm.
right? So that's a pertinent part of this case. That, okay,
Hmm.
does she have previous pregnancies? She's 30 years old. Probably in Pakistan, she probably has had 3 kids already. Um,
Hmm.
so okay, that's my point. So anybody who's listening, they will ask these questions.
Hmm.
How many pregnancies? Has she had preeclampsia before? Um, any past medical history that she's had? Um, so yeah, chief complaint, um, past medical history, history of present illness,
Hmm.
um, review system, pertinent vitals, um, and just go through the line. Just go through an important physical exam finding. You can say there was no significant physical exam finding. The
Hmm.
baby was appropriate to age. So in any pregnant patient, you always have to mention, how many weeks gestation is the patient in,
Hmm.
right? That's a very significant um, point whenever you're talking about any pregnant woman, any. Um,
Hmm.
so yeah, just go down the list, and um, it was good that you mentioned what you did with the patient. So that's very important. You have to, of course, mention what you did with the patient. That's very important.
Hmm.
Um, yeah, I think just structure it a bit more. The best part I liked about your answer was you tried to explain that you were with the patient for all this time, you were giving all the medication, this and that, and you followed up later. Um,
Hmm.
so yeah, that was good.
Thank you very much.
All right, who's next? Who wants to give it a shot? Who has an interview coming up?
Can I try
Sure,
next?
I can never refuse.
Um, all right. So I had this patient come into, I received this patient in a hospital that I was working in after my house job. And this patient came in with upper GI bleed and it was linked to NSAID use. Um, Once he was stabilized, he was ready to go home. He did not want any evaluation uh, apart from the H. pylori testing that was done during endoscopy. He was like, I know this was because of my back pain, and I'm just going to stop using NSAIDs from now on. That's it. He did not, when I asked questions, when I communicated with him, like, we need to know the reason of your back pain because you don't have any comorbidities. And you're a young man. He was a 55 years old male. Sorry, I will make sure to sentence it little bit better, phrase it a little bit better. Um, this was a 55-year-old male with no comorbidities, and it was a challenge for me to communicate how necessary the evaluation was. Somehow at last, I was able to convince him to undergo evaluation, and we found out he had hypercalcemia, acute kidney injury, and we found multiple myeloma. And he was not very pleased with that diagnosis. He said, "I knew you were gonna find something. That's why I didn't want an evaluation." And he was reluctant to start the treatment. Again, I had a session with him. I counseled him how this cancer is treatable, and I was able to get oncology consult, and the treatment was started. The interesting part of this disease was that patient, they did not present initially with the symptoms of multiple myeloma, and if we didn't uh, insist on evaluating him in detail, we wouldn't have found the cancer. He would have lived not knowing that he had a cancer diagnosis.
Okay, so all right. So did the lab work happen first or the EGD happen first?
EGD happened first. The lab was done just for anemia.
Hmm. Okay, that will be interesting. EGD just happens first before the labs. The
Yeah,
patient came into the ER, the patient came in outpatient clinic.
ER. It was an ER.
Right. Okay. I mean, what do you guys think?
I feel like if he was in a government hospital, he would have had all the labs done in the emergency. But if it was a private hospital, he just underwent uh, CBC for anemia, and as soon as the results came in, they took him to endoscopy.
What was the CBC result?
Well, it was 5.4.
What was 5.4? The WC count was 5.4. What was 5.4? So hemoglobin was 5.4, right? Or what was 5.4?
Sorry, I had some internet issues, I think.
So what was 5.4?
His HB was 5.4, and hematocrit was also low. And also, he did not have pancytopenia on CBC.
So, okay, so step back a little bit.
Mm.
Was he having bowel movements? What was the color of his bowel movements? Was he
Oh, it
vomiting?
was just an
So did he present with, so 55-year-old male presenting to the ER with what? He just presented. What was his chief complaint? Why did he bother to come to the hospital?
sorry. I think again I had some internet issues. What was the question?
So why did he come to the hospital? What was his chief complaint of coming to the hospital?
For hematemesis. He was like his coughing of blood. He was saying that he was vomiting. Then at the end of the vomiting, he started coughing, and the cough had some blood in it. It was a very weird case.
Okay, no, that's fine. All right, so let me try to see if I can present it. Um, okay, so okay, let's see. I had this interesting case that walked into an emergency department for a private hospital, and this was a 55-year-old male um, presenting with complaints of hematemesis um, with no significant past medical history as per the patient. He had complaints of hematemesis for the last day, where he had 2 episodes of bright red blood in his vomit. This was not associated with any significant abdominal pain. I'm just plugging things in because I think these are pertinent things to answer or not answer, right? Or at least have. I this was let's just say this was associated with epigastric pain. He denied any associated diarrhea with his presentation. Otherwise, no significant physical exam, no significant review systems other than feeling fatigued with aches and pains. for which he admits that he was taking NSAIDs frequently over the past couple of weeks. So, myeloma can cause bone pains and different issues, right? So, this point I'm adding just to fill in your gaps that he was having different bone pains, especially in the ribs, perhaps. Um, vitals, no significant finding on the vitals. Normotensive heart rate within normal limits. Otherwise, physical exam findings noted pallor. Otherwise, non-contributory. Lab work was obtained demonstrating low hemoglobin of 5.6, low hematocrit. Platelets were within normal limits. PT-INR within normal limits. So you're talking about a case of bleeding. So you have to explain what a doctor will want to know, your attending will want to know. See, bleeding, what do you need to know? Is it bleeding? You're talking about the pertinent positives and pertinent negatives, right? You could add in the physical exam, there was no evidence of petechiae or bruising noted. So you're talking about pertinent positive, pertinent negatives. Otherwise, lab work showed hypercalcemia with a calcium level of, let's say, 12.5, whatever. Creatinine noted to be elevated. So you're talking about multiple myeloma, right? Multiple myeloma can have what? Right? All of these things. So, so we talked about lab, we talked about physical findings. So I don't know any so in one initial test after so due to his low hemoglobin, we had suspicion due to his low hemoglobin and presentation, we suspected upper GI bleed, likely of gastric origin. Although his vitals were stable, we initiated blood transfusions. So that is a very important. I think no one will just jump to an EGD immediately from the ER. I mean, if they did, this is a bad case to present.
Oh yeah, they did transfuse blood. Sorry, I didn't mention that. They transfused blood and then took him to to EGD.
Okay, so initiated blood transfusion. The patient was referred to gastroenterology. For the acute phase for the patient received an EGD demonstrating a gastric ulcer secondary to likely NSAID use due to the other lab findings with the hypercalcemia and AKI, which we investigated with urine studies, including urine sodium, urine creatinine, osmolality testing. This was likely due to intrinsic renal disease. If you remember the FENA, the fractional excretion of sodium calculation, right? I don't know if you remember what was that, if they did it or they did not do it.
They didn't
Um,
do it. They did plasmapheresis and
Gotta find a better case then. This is a good case, but you
okay.
you have to plug in the gaps.
Okay, yeah.
So um, this given this triad of symptoms, there was a consideration for multiple myeloma. We obtained a hematology consultation, and on further investigation with what? What did they do to investigate this? there are other things that happen multiple myeloma on basic labs. What was the albumin protein ratio, right? So there's going to be a disassociation with that, right? Um, then um, they did imaging studies. X-ray of the rib showed what would X-rays of the ribs or pelvic bone show in multiple
So
myeloma?
uh, he didn't have any osteopenia there, but he had osteopenia in his skull.
Okay. So what? So let's say osteopenia.
Not osteopenia, sorry. The, what is it called? Sorry, the coin-shaped lesions.
Okay, some lytic type lesions and
Lytic lesions. Yeah, sorry.
mineralizations in different areas, patchy. So um, then what do they do initially to evaluate for multiple myeloma? I mean, we have a strong hunch. What would they do?
Plasma and urine electrophoresis. I'm not sure it's electrophoresis or sorry, मेरे से निकल गया.
UPEP, SPEP. Yeah. So
Yeah.
UPEP and SPEP, right? So
Yes.
and what would they find? Gamma spike.
Um. Yeah.
Okay. So right. So you gotta know the case. You gotta know the case. Right? You gotta know the case that
If
you're talking about.
if I were to prepare this whole, I feel like it's a really lengthy case. Should I just move on to another simpler case?
No, I like this case, but you just need to know about
Okay.
it. Just plug in
Okay.
the details.
All right.
Uh, yeah, plug in the details. Um, and you can say this was interesting because he came in with upper GI bleed and he was taking NSAIDs for the pain caused by the multiple myeloma. And we ended up finding multiple myeloma as the root cause of his presentation. So I like this case. Okay.
All right. Thank you.
All right. Who's next? That's why nobody showed up today.
Question. I have a question.
Sure.
Question is, like just my experience is like this that I don't have a very interesting case during a house job, or I cannot think of any, but during my observership, I have plenty, which I think might be interesting, but I'm not directly involved because I was an observer. At one point, I might be a little bit more involved in one of the observership, but again, it's just an observer part. So what would you recommend? Go back to house job again and see if there is something to salvage?
You gotta have something because you cannot be go into an interview without having two or three cases ready.
No, I have a two or three cases in mind, but all of them are mostly what I have seen during my observership, or I might or might not be directly involved with it. So that's the issue.
Okay, so I still remember the cases that I presented.
Okay.
Okay, so one was tubercular ileitis, right? Those are cases that you can find in Pakistan, you cannot find in the US.
True,
Heart's
true.
disease with tuberculosis, miliary tuberculosis. You probably saw tens of these patients. Come on.
Yeah.
Probably saw tens of these patients. I remember our wards are filled with these patients.
Yeah, but we don't
You can
think
talk
it
about
is as
malaria. You can talk
interesting,
about a
right?
case of dengue fever.
Oh, yeah. Yeah, we have seen
When I
the,
did my house job,
yeah.
actually didn't do much house job. It was back in 2007.
I mean, I if I look into that. I don't think that's interesting. So
Why not
I
interesting? You need to present a case.
right. Okay.
Um,
Okay.
Use me,
Dr.
doc.
I want to ask a question.
Sure.
Basically, if I have written a case report over here during my observership time period, so should I present it, or should I choose some case from house job? Because I do have cases from the house job as well.
So you can present a case from anywhere, but you just need to present it properly, and you just need to know the details of your case.
Yeah, I do know the details, and I have written the case report on that case as well.
Right, definitely. So that's it.
Mhm.
That's it. Um, so yeah, just whatever you do, make sure you're speaking in medical terminologies. You're speaking in the flow pattern, chief complaint, past medical history, history of present illness, pertinent review systems, physical exam, pertinent vitals, pertinent positives and negatives for everything. Pertinent positive of review system, pertinent negative of the review system, right?
Mhm.
Pertinent physical exam, initial investigations, including lab work. I did not go through the whole CBC when I was talking about Asma's case. I just mentioned the exact things that's needed. Pertinent physical exam findings, pertinent radiological studies. So if you know the case, you can present the case within 30 seconds, 30 to 45 seconds, if you know the case. It's not going to be long. If you know the case, you can present it pretty quickly.
Mhm. But from the observership point of view, we're not the part of direct patient get involvement. So will it make it a weaker case?
Well, you have to you listen. They want to know what you are capable of, not what somebody else did.
Mhm.
They want to hire you, not somebody else, right?
Mhm.
They don't want to hire the resident who's already working in some other hospital. They're looking to hire you. So what was your involvement in that case? Like Sabdar mentioned about that he was there for 4 hours, he was giving all the medication. So you have to suggest what did you do? The case that I presented, oh, this was the patient that I admitted, and I was taking care of the case, and I was following the patient for 3 days. Then I followed up the patient later on about the biopsy result.
Got it.
So, oh no, my resident did this. Oh, my attending this. Oh, I didn't do. I just read the chart. That doesn't make any sense, right? Okay.
Mhm.
They won't hire me because I read the chart and regurgitating the chart. What did I do? I witnessed that case, right? So that's, I mean, do you guys see what I'm saying? That's my next question possibly.
Yeah,
So
yeah,
they
I
want a
got it.
person, especially if you say you did your house job, you did this, you had 3 months in medicine, or you had, you did a whole ENT rotation, perhaps. Um, so you just need, because they know that anywhere on earth, if you're doing a medical officer job or a house job, wherever you did anything, you always have to present in the mornings. They just want you to see, they want to see if this guy, do we have to teach this guy presentation skills, or does he already have presentation skills? They will prefer the candidate who has presentation skills, right?
Got it.
Okay. Who's next? Why are you hiding your face, Adina?
Not hiding. I'm just trying to think of something that I came across during house job. I cannot think of any. To think of one thing, I think during ICU rotation, there was a case, but that's already, I don't know what I did for that patient in
They
particular.
give you diabetic ketoacidosis case, right?
Yeah. Yeah, I mean that's easier. That's not a
Give
very,
me, no, you present a diabetic ketoacidosis. You should, how many times you've seen a diabetic DKA patient? 20 times, right?
yeah. I
Okay.
mean, like quite a
They're all
bit.
the same. They're all the same. Present.
Okay. Um, so yeah, I came across a patient during my medical floor rotation during my internship here, and the patient was 21-year-old female. She presented with the complaints of nausea, vomiting, and abdominal pain. We did end up getting her labs, and
You don't get labs immediately. You tell about the patient's past medical history.
yeah, sorry. So patient's past medical history was significant for type 1 diabetes. And other than that, everything else was unremarkable. Physical examination.
Step back a little bit. Patient coming in with nausea, vomiting, abdominal pain, vomiting. Whenever you say vomiting, was it bloody, non-bloody? What was the type of vomiting?
Right. So vomiting,
And
the vomit is
other pertinent positive or negative review systems.
all right. Um, the patient, the vomitus was the content of the vomiting was clear, and partly digested food, but no blood and no any no bile or anything. On physical examination, the systems were physical
Post physical
examination.
exam, you have vitals.
Yes. On vitals, she was vitally stable. Um,
Did have tachycardia,
Tachycardia and
borderline and
tachypnea.
tachypnea, and borderline hypotensive.
Okay, borderline
That's
hypertensive
a
because of
typical
the vom.
DKA for you.
Yes. All
Okay.
right. Yes.
Pertinent
And
physical exam findings next.
yes. On physical examination, she has a sweet odor for breath. And other than that, mild
Acetone breath. You can say acetone breath.
acetone breath. Okay.
That's the medical description.
Terminology. Yes. Acetone breath and mildly tender abdomen. Other than that, it was unremarkable. Um, so we
Tender abdomen where?
generalized tenderness.
I give you generalized as well as possibly epigastric. Okay.
Uh, okay.
What
Uh,
rebound?
no, okay. There was no rebound or guarding or anything, any involuntary guarding. Uh, we drew labs, and initial investigation showed um, um,
Back-
acidosis.
Step back a little bit. Any polyuria, polydipsia?
Oh, okay. Uh, yeah, but it was but she has a history of type 1 diabetes. So polyuria, polydipsia, yes, but it was control on insulin regimen. But I think what happened was she missed her doses for quite a bit. For past 2 days, she missed her doses, and now she presented with DKA.
So that's fine. Um so this history about missing her medication should have been in the history of present illness, right? Okay.
Right.
You'll add that there. Now you are talking about pertinent labs, right? After the physical exam, what were your investigations? Lab and imaging studies.
Yes. The WBC count was normal. But she showed some metabolic acidosis with a pH of 7.2, and low bicarbs. And she also the glucose levels were very high at that point, and the urine analysis also showed glycosuria and ketonuria. Um, we made a diagnosis of diabetic ketoacidosis on her labs and initial presentation. And
What type of, so you did an ABG, you got a pH, right? Or you did a
mm,
BBG?
ABG. We usually do ABGs in Pakistan. Here we do VBG.
So, what important aspect of the lab work you missed?
Electrolytes and lactate or
And
something. So anion gap, right? Okay. Yes, anion gap.
okay, continue. That's fine.
Yes, anion gap shows she has a raised anion gap, and potassium was also on around 4.5. So we started her on IV fluids along with insulin drip, and also with the we were also trying to replenish her potassium, and we try to manage that patient until her anion gap closes, and then we try to switch it over with subcutaneous insulin. We overlapped the IV drip with with subcutaneous insulin over 1 or 2 hours, and as soon as she started and after a day or two she started feeling better. She was able to eat, she was able to um, mm, uh, she was doing better, and her labs are also getting better and on baselines. So I think that's all.
Okay, so so you see,
Yes, I
any
see.
question that I asked was very relevant.
Yes.
Okay, and you need to be ready with the case. You need to know
Mm-hmm.
the important details, and they want to
Mm-hmm.
see if you're able to present a case. So,
Yes. But
Adina, Safdar, Hassan, Asma, I think you guys presented, and
mm-hmm.
we poked holes in the case because because they want a resident, they want a person, they want to hire a person who actually knows how to present a case. So I think you guys understood today that the importance of knowing the case and making sure that all the medical relevant details are there in the case in your presentation. If you don't know the details of the case, okay, make sure, and you can't find the records, you know, plug in the details, make sure that those details are correct. So, but you need to have, at least for New York, Philadelphia, community hospitals, you need to have at least two cases ready to present with all the facts and figures, right?
The only problem is to find the case that I want to present.
But we just talked about this
The
DKA case,
present.
right? So now
Mm-hmm.
you can plug in all the gaps that you had in the presentation, right?
Right, right.
Write this case down now.
Yes,
This is your
definitely.
case to present,
Okay.
okay?
Okay. All right. Perfect.
Find a meningitis case, develop a case, very typical. You
Mm.
said this was
Yeah, I
interesting
got
for
it.
me
I got
because
it.
this was my first meningitis case. And of course, I had numerous other meningitis cases after this. But this was valuable to me because I admitted the patient. I got the history. I was the one who presented the case to my attending and recommended a treatment protocol for the patient. So but then of course, make sure you have all the details, right? Right?
Yes, definitely. One question. It has to be from internal medicine if you're preparing for an internal medicine interview.
Well, medicine sees meningitis. We see
No,
liver.
no, no, no. That's fine because what's coming into my mind was something from my psychiatry rotation, but I think that's irrelevant for anything.
Yeah, no, again, for any of this, it's just common sense. Most of these questions and answers, as had these sessions so far, how many of you had so far? One, two, three, four, five, sixth session today, right?
Mm-hmm.
It's all about common sense. It's all about common sense, all about real life. And
Yes.
it's all so the
Okay.
purpose of these interviews are normally, I mean, back in the day when we didn't have these sessions, candidates will come after flunking and getting humiliated at a couple of their interviews. They're
Mm-hmm.
like, "Oh my God, I messed up my first two, three interviews," and now they're stressed out.
Mm-hmm.
So
Mm-hmm.
this, hopefully, by these sessions, you guys are ready and better than most other candidates who didn't get the opportunity to do something like this. So you're
Yeah.
already prepared. and you don't have to suffer this in the interview. You're suffering this right now.
That's that's true, but they're also very helpful.
So no, that's the point. I mean, that's why I plugged in all of these interviews within this month, all of these sessions within this month, so you guys are ready before before your first interview.
Hmm.
Um,
Yeah.
so yeah, I think this was a tough session because that's when fewer people showed up today, because but it's their loss. They go to a community program and they cannot answer, they cannot present a case properly, then that's trouble for them. Okay. I'll give one last try for someone who wants to go ahead. See, we just made up a case of DKA, and this was not even a case that she prepared for. So pick up anything, like I said, we had so many POTS disease in Pakistan, malaria, dengue fever. You guys probably have loads of dengue fever patients that you can talk about, and they would want to know. They would be interested about knowing these things here, right? So those cases, you probably saw 10 patients of malaria in a week. Tell me if I'm wrong. Or different types of TB.
Yeah, I think there was a case that I want to present, but I don't know. So I can make it up. That's what tuberculoma, person with tuberculoma.
Fine. I remember I presented a case of toxoplasmosis.
Oh, nice.
I said the cat came with the picture.
Okay.
That was the interesting aspect of it. We found out later the patient had cats,
Oh, wow. Wow. Okay.
right? Um, so yeah, so anybody wants to go? Rabia Aslam, you're here. You came late, but you're on the hot seat now. Gonna go ahead. Last case for today. It's getting late. I have work tomorrow. I'm not off this weekend. Rabia, you wanna go?
Dr. Khan, I have just told her about the session, so she has just joined. I don't think
Oh.
she's going to
I
present.
have. Okay. I mean, you guys can share with other people. I mean, I've shared this like 3 hours earlier in the group.
So the
So,
most important thing for these
Fazal.
potential, Assalamualaikum. Most important thing for our potential candidates is that you don't have to make a difficult case like tuberculoma or POTS TB or something like that. But what when we used to interview, not anymore. When we used to interview, we just want to see your communication skill during the presentation as well as your some part of medical knowledge, and similarly how you relate 2 plus 2 is 4. So nobody expect you to know current medical diagnostic and treatment therapeutics by heart. So you just have to present any case. Like some very important patients can be sometimes rheumatological diseases, which patient present with a fever of unknown origin, and later on we found out they have vasculitis and lupus or proteinuria or something like that. So make a case which is a little bit unusual if you want to present unusual, but don't go to into details of those cases where you will have difficulty later on connecting. So that's my suggestion.
Yeah, so clarification, I think he's absolutely right. But again, as we went through this hour, you guys realized that missing multiple myeloma has, bone pain perhaps. It has kidney levels could be, creatinine could be elevated. There could be protein issues that we talked about. The basic investigations that are done for that case, you definitely need to know about that. Communicate, and then because you lived through that case, you need to my knowledge, to my understanding, you just need to be able to present the case that happened. And any medical ER or inpatient department, same things happen all over the world. Nothing too different. Um, and so you just need to know the medicine, and medicine is very basic usually. We're not going into genetic testing for a cancer diagnosis, nothing. It's just knowing what the patient came in with, presenting the past medical history relevant history of present illness, pertinent positives and negatives in the review systems, um, vi pertinent vitals, pertinent positives and negatives of the physical exam. What were the basic initial investigations that you are building the story with? Pertinent physical exam findings, and what did you do? What was the assessment? What was your role in that project, in that patient? What did you do? And possibly what did you learn? Or was there a twist in the story? Like I think whose was it? Asma's patient with coming in with GI bleed, hematemesis, um, resulting in eventually resulting in multiple myeloma, for which the patient, for the pain, the patient was taking NSAIDs. So that's a nice twist. So Asma, that's a very nice case that you can present, but just know about the the pertinent positives, pertinent negatives, and yeah, just be ready for it. It's very easy. And Adina, just we just did a case of DKA, right? We just plug in all the relevant details and facts in the middle, right?
Yes.
Okay, Aaron has his hands up. You're the last person today because it's getting late for me, and we gotta sleep and have work tomorrow. And Dr. Fazil, your hand is raised also. You want to go ahead before we get Arun to present his case?
Just a quick thing, last thing, in 30 seconds. Uh, how is it very common these days that they ask the cases, or is it something new? Because it was not the case when we used to interview or when we did the residency, but I'm talking about 30 years back.
Yeah, no, at least we see when I did this about, when was this? In 2010, 9, 10. We definitely had, especially in community programs and New York, Philadelphia, Chicago programs, they would ask for cases. Sometimes they would even give you a case to talk about. So if you have these steps in mind, then even if they give you a case to talk about, you would know how to go stepwise and answering without getting lost. If you just follow the sequence that you probably did every day in your house job, that you presented to your attending in the morning, follow the sequence, the relevant sequence, you would do well in any case that they put forward. And every year, I mean, people are still asking this question. The thing is, if they ask this question and you mess up presenting a case that they know you did a house job and you cannot present a case properly, okay, maybe he didn't do the house job or he just didn't prepare for this answer, which is a very common question to ask. So, I mean, this should be easy. I think you just have to put things down to paper, um, present the case to at least two, three people so that they can, just like I picked up issues in I just picked up basic relevant medical aspects of the presentations, right? Did I go into anything detailed? No, right? DKA, you must know the ANAN gap. The most important thing in managing a DKA is ANAN gap. I think you missed that, right? So I just pointed that out. The basics thing, the basics, no detail, right?
All right.
We're not doing
Yeah.
anything. In Asma's case, we picked out, okay, taking what type of vomiting. You always ask what type of vomiting, and I mean, relevant. Then Safdar's had some points. Then who was the first person? They're not here. Hassan. So it just getting the basics. Medicine is all about basics. There's nothing special about medicine. It's all about the basics, right? Arun, you want to go ahead?
Yes, sure, doctor. And first of all, sorry for keeping you here so late. I also joined a bit late, so that's why I'm presenting at this point. But I would really appreciate your feedback. So, yeah,
Sure.
here it goes. Okay, so this question, takes me back to my internship year where I usually used to oversee about 10 patients on 24-hour long calls. On one such long call, there was this one patient who was admitted for pancreatitis, a middle-aged man who started complaining of subtle yet brief hand weakness in one side and also a facial drooping on that same side. Um, Based on his presentation, but his vitals and everything was normal. Also, when we checked the glucose, that also came up. Patient was like had no hypoglycemia. So what and keeping in the protocol and the facilities we had at our medical center, we sent the patient for a CT scan, which came out to be unremarkable. But I knew there was something more to the picture as well. So I discussed this with my senior doctors as well as the neurologist on call, and they suspected a TIA at that point. And I requested if the patient could be transferred to another facility for an MRI scan, and they all agreed with me what the plan I had. So I went with the patient to get the MRI done, and for because of this, we were able to diagnose carotid artery stenosis, which led to the TIA, and the appropriate interventions were made for the patient. So this particular case has, like taught me the value of being curious and being vigilant in such a settings.
Okay, I'll let somebody else comment on this since we spent an hour commenting. So I think we learned a few things probably, right? So let somebody else comment first. Let's see what you guys suggest. Give him some feedback.
I was just curious about like the further management of the patient because I think we stopped kind of at carotid artery stenosis. Then you said like you did like the relevant management, I think something like that.
Yeah.
So do you know what that was?
Yeah, so basically, like, the clot with some clot like removal was done at the other facility, and like the case was taken from us. So at that point,
Anybody else?
Yeah, I think we talk about the structure. So again, everything has to be the same way that you're presenting to an attending. Chief complaint. Then he did all this thing with every one of us. That chief complaint, vitals,
You complained, past medical history,
yes,
open
vitals,
illness,
physical
and
exam.
positive reviews of symptoms, then pertinent vitals, pertinent physical exam. So the other thing that threw me off a little bit, you said a case of pancreatitis perhaps, but then
so,
had weakness of the upper extremity, etc.
so yeah,
Uh,
the patient was admitted to us for pancreatitis, but when I was doing a round with him,
but the
he
CAT scan was
confessed.
negative of the what was the CAT scan about?
CT scan of brain, yeah, was negative
Of the what?
of the brain for seeing a stroke, but there was no sign of stroke.
Okay, so the patient was already in the hospital for pancreatitis,
Yes.
and then he suddenly developed.
Brief signs of neurologic signs of hand weakness and facial drooping, which we could not notice. I should mention it, but on our examination, there were no such signs. So we were also suspecting electrolyte imbalance as well as any hypoglycemia.
So he complained of weakness. So okay, so he complained of weakness and difficulty articulation, right? This
Yes.
RCM.
Yeah.
But there were no physical signs that you noticed.
Yes. I
Okay.
should have mentioned it. Yeah. Like when we did the examination, we didn't know.
So it sort of goes against your final conclusion. The patient possibly had, so it's a TIA versus a stroke.
Hmm.
Um, so nothing was found on the CAT scan,
Yeah.
right? And did you do any subsequent imaging? Because if a suspected TIA or a stroke, you always have subsequent imaging.
Yes, so we did MRI angiography, which showed carotid artery stenosis, and that's what we suspected was could have led to TIA
Did you do the MRI angiography
of the neck.
or after the MRI of the brain regular with diffusion weighted imaging? And did you do a carotid ultrasound before any of this?
No, no carotid ultrasound. I think that when we went to the other
Or
facility,
straight to the angiography? I don't think people will go anywhere straight to angiography using an MRI. They will first, because MRI is difficult and costly. Usually they order a carotid ultrasound first when you're evaluating for a TIA or a CVA. You'd want to do a carotid ultrasound, echocardiogram before, unless MRI is very easily available. And then you may want to do an MRI of the brain, diffusion weighted imaging, along with possible carotid angiography, right?
hmm,
So you didn't mention anything about the MRI of the brain. Um, you did the symptoms resolve completely?
on our examination, there were no symptoms of weakness.
Did the patient still complain of the symptoms?
No, the patient said it was a brief episode.
Yeah. Okay. So in this situation, you would always say that the MRI was also negative. The patient could have complete resolution of symptoms, but still MRI of the brain may show an acute stroke.
Okay.
right? So that was a very important aspect to mention that, okay, the MRI of the brain was negative for any acute ischemic findings. However, MRA demonstrated a carotid stenosis. And then whenever you say carotid stenosis, how much was it?
As far as I can recall, it was more than 90%.
Okay. Okay. So
And it was bilateral.
yeah, it was, but okay. So that is an important point you have to mention, right? Why?
Because I think less than 70 does not need to be treated, and more than 70 has to be treated. This is what I can recall from my
Yeah.
memory.
On most occasions, yeah. So that's why you have to mention that, right? And what do you do for that?
And there was this procedure, something like how you remove this like
Carotid
clot
endarterectomy.
and arterectomy. Yeah.
Okay. So I would step back a little bit and to present the case in a different manner. Um, and you can say this was an unexpected event, and you have to mention what you did in this case, right?
Okay. Yeah.
So I would, step back a little bit. How old was the person?
He was like around 50s.
In the 50s. We actually had yes, I remember this case in my internship year. And I was the admitting intern. You were the intern probably, right?
Yeah.
Admitting intern for this. I was the intern following this case. This was a 55-year-old gentleman with a past medical history of diabetes, hypertension, who was actually and alcoholism, was actually admitted to the hospital with pancreatitis. Um, he has been on treatment for such for 2 days, and he was trying to do well, and was trying to have more adequate oral intake. Subsequently, in morning rounds, he complained that overnight he developed right upper extremity weakness with slurred speech that lasted for around 30 minutes. He had alerted the nurse. However, the nurse came in late, and most of his symptoms had resolved. On our associated with this, his symptoms, he denied any diplopia, flashes of light. He denied any other tingling or numbness sensation, just the weakness in his right upper extremity with this arthria that resolved. He also denied any dysphagia with this episode or subsequent a morning meal. Otherwise, vitals within normal limits. Pertinent physical exam findings. We could not appreciate any significant neurological examination. The patient was alert or in types 3. Otherwise, his abdominal examination for the pancreatitis with serial abdominal examinations all have had improved by this time. Subsequent, we had concerns for a possible TIA for the patient. We had ordered stat CT of the head, which was negative for any acute findings. Given the physical exam, we also, stepping back a little bit, we did appreciate a carotid bruit on the right as well as the left, which was apparently missed earlier on when the patient came in because we did not examine from the neurological standpoint. Uh, we were suspicious of carotid artery disease. However, of course, for a possible TIA versus stroke workup, we obtained an echocardiogram as well as carotid Doppler. It seems you guys just went to the MRI, right? So we
Yeah.
obtained an echocardiogram, and we ordered a MRI of the brain with diffusion weighted imaging as well as MRA of the head and neck. MRI of the brain was negative for acute ischemic findings. However, we confirmed carotid stenosis bilateral, more than 90% in bilateral internal carotid arteries on both sides, confirming a suspicion for a TIA versus a CVA. The patient subsequent, because of these findings, received an endarterectomy with vascular surgery. So this was an interesting case that we apparently had a change in event and a significant event during the patient's hospitalization because he came in with pancreatitis. Subsequently, due to his risk factors of diabetes, hypertension, that he has vascular disease as well, resulting in this TIA. Uh, it was interesting for me because, well, definitely I was managing the patient as the intern, and I've also evaluated the patient in the morning when he described that he had this event overnight. Yeah, this may be a common occurrence, but to me this was very special because it's my first case of a stroke presentation in the hospital. Hopefully, you found this interesting as well.
Makes sense. Perfect. Yeah, makes total sense. This
Okay.
this is much better. Yeah.
So yeah, that's the basics. I mean, I didn't say anything special because there's nothing really special. It's you just need to know how to present the case. All right.
Arun, you presented the case very well. With you need to add some additional descriptions, like Dr. Umar is saying, but you did very nicely presented. It has to be a little bit more elaborated.
Thank you so much, Dr. Ali. Means a lot.
All right, guys. All right. So until next time, right? You guys have the calendar, right? So we're just following the schedule that we put out earlier in the month. Okay. All right. Sounds good. Thank you so much.
Thank you.
Thank you very much.
Thank you. Allah Hafiz.
Thank you, Dr. Han, Dr. Fazil Ali.